have some twitching, but their neurological status, they're severely confused. They're not with you. They're gone. They're not with you. So they may go in and out of that for about 30 minutes, and then if they keep going past that, then you can say, okay, this is an emergency. Now, it's unlikely that these are going to stop. This patient's brain is in this vicious cycle, and it's just going to keep going and going. Now, this is the time when the family member probably is going to be calling 911. Or, and this could be in any types of seizures, and where we'll talk about partial seizures, generalized seizures, or focal seizures. Partial seizures, the old nomenclature, focal or generalized, but whatever type of seizure that it is, they may be half alert oriented, but they're still not fully back normal to their neurologic status. Or you can have a patient that's seizing your tonic-clonic generalized. This is a patient who is convulsing violently on the floor, foaming, peeing themselves. And so this is, they collapsed, so they're starting to seize. Most patients, if they have a history of seizure disorder, the family members are going to know approximately how long this patient's seizure lasts, if they have a family member right there present. So they'll say, usually this may last 2-3 minutes, but this typically does not go past 3 minutes. So family member looks, okay, this has been going on for 3 minutes, and it's not even close to this patient coming out of it. So this is when the ambulance gets called, or close to 5 minutes. If the patient is violently convulsing on the floor for 5 minutes, this is now becoming an emergency situation. This is now status epilepticus. And it's very likely that seizure is going to stop on its own after 5 minutes. So the incidence of status epilepticus, depending on which sources you look, about 10 per 100,000 to 40 per 100,000 in various databases. So your patients that are at risk for going into status epilepticus, this is not talking about risk for seizure disorder. This is talking about emergency side of seizure disorder. But these are the patients that are young and you're elderly. And the highest rate of mortality, of course, is in the elderly, and a lot of this has to do with comorbidities and other chronic illnesses that this patient has, and probably multiple medications that they're on as well. More than 50% of patients who go into status have no history of epilepsy. So this may be in the emergency room your first time that the patient presented with a seizure disorder. Now, not every seizure would need to be on medications going forward, and we'll talk about that a little bit later. And if they had a seizure, they went into status, there may be a cause for it, and they may never have another one again. But so it does not necessarily mean a lifelong diagnosis of epilepsy. But this may be a first presentation for some of them. The other 50% that do know that they have a seizure disorder, and then they go into status, if they're seen regularly, even by primary care, if they live in a rural area and the neurologist is too far away, whatever the case is, and they're probably on some anti-epileptic drugs. Number one cause that you'd see status epilepticus in these patients is usually medication non-compliance. Cost can be an issue where they can't afford their medications, they run out of them, they may try to stretch them. It's a twice-a-day dosing. I may not know for months that they've been taking it only once a day, and they ride that wave until they have a seizure, and then finally they admit to me. And so that would be and sometimes when we change seizure medications in a clinical setting, I always warn my patient that every time, if we do everything right, and we'll talk about that a little bit later on, how to correctly, perhaps if patients changing from one seizure medication to another, they're still at risk because they were controlled on this one medication, and now we're taking that off and putting them on something else. So they're at risk for breakthrough seizure and in rare case status. You've got two stages in the status epilepticus, and the main reason why I mentioned that in here, your one that I've talked about, where let's say patient fell down, they're shaking, they're convulsing, they bit their tongue, and this is typically has some tonic muscle contractions that can be pretty impressive. You're going to look at this patient, you're going to say, okay, they're having a seizure. And that would be easy to diagnose if a family member saw that from someone in the middle of the living room. But let's say it's an elderly patient, let's say it's a patient who has dementia, who can't tell you very good history, and let's say that family member found them in generalized non-convulsive status epilepticus. So they were convulsing for some time, and now they're still in status epilepticus, but there's no more of this violent muscle contraction. So they're not with you. Their neurologic status is not back to baseline. They may have subtle jerking of the face, eyes, and extremities. So, and they may still convulse a bit, but you can have a much less of an intense motor activity. So it can, if this is their first seizure, it can be a little bit challenging to come up with diagnosis as this patient arrives in your emergency room. And so in that patient that you're not sure, these are the patients in the hospital setting, in ICU, in the emergency room, once they're hooked up to an EEG, when they're in the status, and the EEG, the best way I describe it to my patients is like an EKG, only it's an electrical activity of the brain. So these patients can flex leads on their head, and we'll talk in a lot more details about EEG down a little bit, but the EEG is going to be abnormal. It's going to have some abnormalities on there that your guys are not going to be reading EEGs. This is going to be a board certified neurologist, but it's helpful to kind of glance at it and know some basics. So the convulsive more rapidly, convulsive is more damaging, I already talked about this. So this is the patient that you find with altered mental status. You didn't quite see them convulse violently, and now you're trying to figure out where, what's the diagnosis. Get ahead of myself. So we will talk about causes of seizure, potential causes of seizure, whether it's a single isolated seizure, whether it's provoked seizure, or whether this patient is most likely has a diagnosis of epilepsy where they have a lifelong diagnosis and they need to be on medication. And it's very similar, again, with the status epilepticus. Status epilepticus is just the emergency side of epilepsy or seizures. So you may have something in the brain that is just one part of the brain that just, what I described to my patients, just became overexcitable without going into too much pathophysiology. And then the abnormal electrical activity spread. And so that part of the brain may look healthy on an MRI or brain imaging, and the patient will have no deficits or neurological limitation. It's just that's where it started. They may have had a stroke, they may have had a tumor, they may have had a bleed in their brain, they may have had a trauma to their head. This patient fell from a ladder of 12 feet, hit their head, and then they started convulsing. So there's some type of insult or some type of scar tissue in the brain where that abnormal, around which that abnormal electrical activity can start spreading. Or you can have a metabolic state where a patient is, there's some type of other illness in this that it's send them into status epilepticus. It's a byproduct of it. They may be hypoglycemic. They may have a really bad undiagnosed thyroid problem, and the list goes on and on. So it can be more of a metabolic state, some other condition that send them into it. You can also toxic metabolic. Toxic is more of a substance abuse, and we'll talk about that a little bit later. Even drugs, alcohol, maybe have say overdosed on the medications and so on. So I won't go into too much of the pathophysiology on the molecular level. You guys had probably some of that. But the reason why I mentioned these rapid changes in protein phosphorylation, opening and closing of the ion channels, and release of neurotransmitters and modulators. That's kind of a first stage in this overexcitable brain state. and most of the anti-epileptic drugs work in some shape or form at this level. Although there's some that we don't know the exact mechanism of how they work. We know they work, some of the newer ones. So the more neurons are excitable, the longer this goes on, the more likely that you are putting these brain cells at risk. Our brains, these cells are not, this is not their natural state. They're not meant to be discharging this rapidly. And so at some point, your motor neurons are gonna start wearing out. So if you let this go for about 60 minutes, now before that, there's gonna be lots and lots of other problems that your patient's already gonna have developed, and we'll talk about it later. But this is at about 60 minutes, your motor neurons are probably going to start dying. So you're looking at your patient having permanent brain damage from being in status for that long. Your guidelines for treatment, you will need to have a plan. Most of the hospitals in the emergency rooms would have a protocol for status epilepticus, and I have doses on here that I got from a neurology, American Academy of Neurology continuum that I've used. I was about 2 years old, but the hospitals may have a slightly different protocol. There may be a drug I'll mention here as a second line that a hospital say, no, we don't use that one, we use this one. And so it's kind of a very general overview. I'll talk about specific things that you don't want to do as far as the doses. So one hospital may prefer use a slightly lower dose per kilogram, one slightly higher. As far as the infusion rate, you're going to get a ballpark on approximately what all of the protocols generally look like. But if you see a slight discrepancy in the numbers, some of it may be because of that. We'll talk about being very, very liberal with your doses, so we'll talk about it a little bit later. So what you want as an end result is you want this patient to stop seizing. And by stop seizing, I don't mean for them to lay still, because they may be laying still and not moving, but their brain is still going haywire. So we'll talk about that later. You're gonna put this patient under general anesthesia and you're gonna sedate them so they're not moving anymore. That didn't do anything to the electrical, the overexcitability of the brain. That keeps going. So the brain damage is still a risk. You're still gonna kill your patient. So you would want seizure to stop, which means we're gonna use anti-epileptic drugs at high doses, as fast of an infusion rate as we can possibly give them safe, and load them up until we see kind of a good, nice baseline on the EEG. And again, this is not a clinic patient. This is not. This is a hospital patient, most likely an ICU patient. If they've gotten to the point to where you're starting to use some powerful IV meds. So you the longer, and I've already talked about this, the longer you wait to treat this, the more you're risking patients to be sustained permanent brain damage. Meanwhile, they may also be going into respiratory distress, and they may be going into acidosis. They may be, they're in your hypertensive patient on multiple meds. Their blood pressure may be through the roof. So there are other issues that arise from patient being in status as well. So you want to treat them fast, and you want these to stop. I've talked about this a little bit already. You want to avoid narcotics. Your patient is unconscious. They're not feeling a whole lot of pain right now. Their mental status is so. Narcotics are going to suppress your respiration. Your COPD patient, your obese patient, this is just how you get them to stop breathing. Hopefully, when they're in the emergency room, still seizing, you're getting, ABCs, you're getting their airways taken taken care of at that point. You're getting them intubated, you're getting their vitals, you're getting the catheter, you're drawing blood, you're getting them stabilized. So you don't need narcotics. Phenothiazine's more of an antiemetic class that actually lowers your seizure threshold, puts you at risk, put the patient at risk for a seizure. And I'll talk about medications to avoid down the road on clinical basis as a practitioner in patients have a seizure that can actually send them into a seizure. And again, paralyzing agents, just because their muscles are not moving doesn't mean their brain is happy. So you may use something just briefly to put them to get them to stop moving so you can intubate them. And then that's about all that the role plays. So hopefully by the time the patient had arrived into your emergency room, they have received an IV lorazepam or Valium, at least 1 or 2 loading doses. Paramedics on site should be able to do that. If not, then that's what you'll be doing. But the faster you administer IV benzodiazepines, the better. We'll talk about doses right. So this is the table I was talking about. When your patient is first arrives to emergency room, hopefully the paramedic have given them a good loading dose of lorazepam. If the patient was seizing, they got another good loading dose. By the time you go over, you hear on a large patient, it may take up to close to 8 milligrams. On a thinner, smaller patient, and maybe even less, but you're going to start suppressing their respiration. So you're going to need to work on intubating this patient if they're still seizing. And we'll talk about all of these medications, and I'll probably come back to this slide here over and over. There was a study, again, trying to administer benzodiazepine as soon as possible, so lorazepam or Valium. Lorazepam is what I've seen used the most, but I know some doctors prefer Valium. Some of this can be just hospital and doctor preference. This would be your first line drug, and you want to administer it as soon as possible. There was a study trying to look at the IM benzodiazepine rather than IV. This is going to be IV. And so if you shoot this patient with auto-injector as fast as possible with 10 milligrams at the earliest you possibly can, ambulance, the emergency was right around the corner and they arrived literally within 3 minutes. And the earlier the better, then you may actually be able to stop their epilepticus. And in this study, up to 73% of them, when this was auto-injector was right there, patient was injected, it stopped. So you still need to take this patient to the hospital, though. But they were not in status anymore. And the IV lorazepam was 63%, but they did not use higher than 4 milligrams of lorazepam because if you start using more than 4 milligrams, this patient would most likely need to be intubated. So. Lorazepam. So you're looking at about 0.1 milligram per kilogram at rate of 2 milligrams per minute. At that time, if you've given them already a second dose, so they got their first dose in the ambulance, you're giving them the second dose in your emergency room, then you're starting to get a bag of a third line agent ready. You're calling your pharmacy, and they're getting whatever the second line agent is preferred in your hospital. Probably going to be phosphinatoin, but if they got phosphinatoin allergy, maybe Keppra or maybe that IV, and we'll talk about that a little bit later. So you're looking to see for an effect for them to stop status in a few minutes, and hopefully that would happen. You can use Valium, and you can go back to that chart to look at the dosing and the infusion rates. So, I will talk about phenytoin a little bit here, and I talked about this first because of the adverse effects and side effects with IV phenytoin, but unless this is the only thing that's available in your hospital, don't use it. There's too many risks. Fosphenytoin IV is the way to go. With phenytoin, you want to, if you look at the very bottom of this chart right here, with phenytoin, you want to use 18 gauge or larger needle. You want to place it in intercubital fossa. You want to find that large, good artery, vein, and you want to infuse no faster than 50 milligrams per minute. And the reason is because you're going to put them at risk for subcutaneous infusion or necrosis or purple glove syndrome or venous sclerosis. So their veins are not going to be happy. And it's going to look like this, or it's going to look like this. So we want to avoid that. You don't see that with fosphenytoin unless the patient has dilantin allergy. So if the patient has phenytoin allergy, then you can send them into Seizures-Johnson syndrome with either one of these drugs. They're similar in that the allergies, they're allergic to one, assume they're allergic to fosphenytoin as well. So fosphenytoin is your drug of choice, and it is per drug that's converted into phenytoin in liver before excreting any other therapeutic effect. There's no tissue toxicity, again, unless you have an allergy to dilantin. And it can be given at a faster rate, although you've got that conversion to phenytoin in the liver time, so the therapeutic effect may not be a whole lot faster, but again, we want to try to get therapeutic levels of anti-epileptic drug in this patient as fast as possible and load them up. We want to stop that status. Keppra would be your other choice, which is actually an excellent drug. And so you got a dilantin allergy, you're going to use Keppra. You can go back to that table for infusion rate. And again, once you let's say you started with phenytoin, you had nothing else, you got lucky, patient's doing great, no allergy, arm's fine, or you started them on fosphenytoin IV, then you're going to, or Keppra, you're going to put them on the drip. So then there's a maintenance rate for them to be on the drip of this medicine. So the status had stopped, but they're going to be on the drip of this medication. And most likely they're going to be discharged from the hospital on these medications too. Oral dose of that. That's what worked for them. We don't rock the boat. Their levels are therapeutic. We got it therapeutic with their IV administration. And you just change them over to oral, and there they go. This is a little side note at how wonderful Keppra is. And that you can always use Keppra. Well, one thing to remember is out of all anti-epileptic drugs, we get scared of side effects, drug-to-drug interaction, tetragenicity, many other things. If you don't do neurology and you see Keppra, you can say, aha, I can safely refill this. I don't have a whole lot to worry about. Or I can prescribe this for you until you get in with your neurologist. This is a great drug. And it's used, let's say you had a patient who had a seizure, medication non-compliance, they ran out of their meds, and I remember last time they took something and what they took, they have a long history of seizures, but you have a reliable family member that came in with them that saw the seizure. They haven't had a seizure in 5 years. I can't believe they came back. Yeah, they came back. They should have been on seizure medications all along. Well, now they're back, so you can load them up with IV Keppra, 2,000 milligrams IV. In 45 minutes, they've got therapeutic level, so they're good to go. With oral, it's going to take longer, so you don't want this patient, they're at risk for another seizure. The further out you go from a seizure, the more your risk goes down, unless you've got a brain lesion of some sort, and then we'll talk about that later. And then you discharge them from your emergency room. You've prescribed them. Most of these patients, if they've had a breakthrough seizure, you're probably going to end up having them on the higher dose. 500 BID of Keppra is the lowest dose I would use for your little patient. But it's a bigger patient, they just had a seizure, you're most likely going to be putting them on the higher dose. You're going to hand them a prescription, and their neurologist can adjust the dose, increase it, decrease it, but they've got something to get them through the weekend or that week until they get in to see a specialist. Valproic acid can also be used. There's a few, again on that table there's an infusion rate and maintenance drug rate that you can look as far as the doses. So you've done your second line agent, you've bolused them once, you've bolused them twice, and they're still seizing. Now we gotta go to our third line. Now, you don't necessarily have to have a second line. If it all depends on the patient. You treat a patient, you don't treat the protocol. You don't look at the protocol, you look at the patient. So there may be time that the second line is going to be skipped. You know, they've got their benzodiazepine, they've got in there, they're seizing, they're in respiratory collapse, they're in arrhythmia, things are looking bad, and you're going to stop this quick. You may be going to a third line, and you're going to be, hopefully, when you're going to a third line agent, you're going to be, they've hopefully already intubated by now. You're transferring them to ICU. This is the patient that you put them under essentially anesthesia, and they're going to be in ICU for a bit now. This is not, oh, we're going to discharge them tomorrow on Keppra 1500 BID. This is a really, really sick patient by now, and you've got an EEG monitoring on that again and again. I can't reiterate it enough. Just because the patient is not moving doesn't mean their brain is happy. So EEG monitoring is what's going to tell you if you stopped that status. This is just an example of an EEG, and I included pictures here, but I talked about an EEG a little bit later. But as you see here, you have spikes and slow waves, spikes and slow waves. So this is a patient who's in status, and this is a patient who is non-convulsive. This is a normal EEG. And again, you're not going to be reading that. I know we read EKGs, but we're not going to be reading EEGs. But your doc may send you to an ICU and snap a picture of that, text it to him if you want to look at it. And you may say, no, it doesn't quite look right. So again, patient in status. And look at your patient too, make sure they're not moving when this recording is done. Because if they're moving their facial muscles a lot, if they're moving their head, you're going to get all sorts of artifact too. Don't freak out, look at your patient, see if they're laying there still. And this is after 8 milligrams of lorazepam. This patient, we loaded this patient, we stopped their status, and the patient returned to baseline. And then every patient who is on EEG is also going to have an EKG on them at the same time. And you see these little spikes right here, and that's an EKG artifact. So you need to make sure that you see those, and make sure the patient is hooked up to an EKG as well. And phenobarbital, I want to mention that here because it's good for ethanol withdrawal seizures. So this is one of those that you may skip a second line and then go to a third line. You treat the patient and their comorbidities. That's a loading dose on that. And again, your patient is heading to ICU at this point. Severe hypotension, very long half-life. Phenobarbital is going to stick around for a long time. So it's going to take a while to get this, to wake up this patient and to get it back to normal status. So again, these next 3 slides, just to reiterate, the faster you treat this with the highest doses you can, the faster you load them up, the better it is. Remember those 60 minutes and you've got a motor neurons dying and risk of brain damage. If you're in the rural ER, you're in the little ER overnight, there's another doc there, or it's only you running the whole show, and you've got that one patient that was in staticus, you've given them Ativan, you think you stopped it, he seems to be doing all right. Don't pull the curtain down and walk away. You may have only a couple of nurses there, not much. This patient is at high risk for having another one, another status. They may not be moving a whole lot, and your patient is going to die. So you got this patient, you think that they're kind of coming out of status, and you need to be working on transferring this patient to a major hospital. You give them a bit more lorazepam, you start all the other IV stuff. This patient needs to be intubated in ICU, so they need to be in the facility that can handle this and that has a neurologist on staff that can be handling this. So again, this is emergency. And the faster they get that lorazepam, the better. All right, now we can talk about epilepsy. This is my favorite part. This is what I see, this is what I'm comfortable with. I don't load patients with IV drugs, I don't do IVs, I don't intubate them, I just see patients in clinic. So you've got 2 types of seizures. You've got focal seizures and you have generalized seizures. With focal seizures, and if you read older books, you may see word partial, so partial and focal is interchangeable, but the new American Neurology Association is starting to prefer focal, and this is, you can have simple focal, or you can have complex focal, and focal is just when you have that one part in one hemisphere of the brain that got overexcitable, and you can see that depending on which part of the brain that happens in, your symptoms are going to vary. It's a small part, only one hemisphere is involved, so there's a chance that your patient may be awake, alert, oriented. When this happens, may be a little confused or may not be confused at all. So with simple focal seizures, these do not impair consciousness, and the patient may experience something funny or unusual. They may see something, they may feel a deja vu feeling, or they may have a little twitch in their arm or their leg. They may cognitively zone out for a minute. And if you have a complex, then you've got some probably impaired or altered state of consciousness. This is not your just arm twitched and that's it. They may be confused. They're not necessarily laying lifelessly on the floor, but they're going to have some confusion most likely. So they may stare into space, they may smack their lips, they may have some abnormal movement of the limbs, and they're most likely not going to remember. Where you're simple focal, they may actually see and be aware of it. You know, I've had another one of those little, and you may have a patient that has more than one type. Now, if your patient has every type of seizure you saw that you know in the books, and if it doesn't make sense, probably is something's not right there. Your patient can have maybe one, maybe 2 of these, but if they exhibit every single sign and symptom of every possible seizure, you may want to, and your EEGs come back normal, you may want to send these patients for neuropsychiatric testing. There's something else going on. This is probably unlikely seizure. But your patient, especially your chronic seizure patient, they're gonna know. And, I had one of those where I lost, did you lose consciousness? Yeah, my brother found me, I hit my arm hard, I had a bruise, I felt really tired afterwards, and then, so, well, yeah, and then I had another one of those where my arm shakes. So you may ask your patient, they may have focal seizures that become generalized, which means that it went from just one hemisphere to now both hemispheres are involved. So they may just have a little twitching in the arm, it's one type, or they may have passed out and shook and lost consciousness and had the event, and they were not feeling well for a few hours afterwards. So generalized is when you have both hemispheres involved. And this is what the most common types of seizure that everybody knows and talks about is when that patient, they screamed out, maybe not, they fell down and they showed blood loss consciousness. I thought this was kind of really neat. Again, I'm fascinated with the brain and how it works. So again, depending on what, for your partial, let's go back to your focal or partial seizures, depending on which part of the brain gets excitable, you get, occipital is pretty rare. I don't think I even never had a patient with occipital where they just have a simple visual aura. They may feel something funny, they may have a deja vu feeling. I had a patient that always tastes something funny, has a metallic taste in her mouth, and she knows that something's not right. They may hear something. They may have a limb movement. So generalized seizures, of course, have different types as well, because our lives can't be that easy. You gotta make it complicated. Absent seizures, and I don't see, it is probably one that I see the least of in clinic, but I do see some. This is the patient that stares into space, unresponsive. They may have an aura, and an aura is some type of symptom preceding a seizure. We also have migraine auras as well. We'll talk about that a little bit later. And then they would have a post-ictal state in some of these, but in not opposites. And post-ictal state is where the patient does not feel well as they're coming out of it, as their mental status kind of comes back. They're really confused, and they get less confused. They're less confused as they come out of it. We can have just loss of muscle tone and falling. You can have a sustained muscle posturing tonic where they just kind of draw in. They may scream out, they may not. They may have trouble breathing. And they may have brief jerking of the limbs. And the tonic-clonic is the one that we know the most. One thing on here to note is Todd paralysis. It's a very interesting thing. I remember the first time a patient called after they had a seizure, and I either forgot about this or haven't seen this in a while. And the patient called me and she said, I think I had a stroke right after I had a seizure. Well, what do you mean? Well, my arm is weak, my leg is weak. And so I'm calling, and I just started working, it was probably my first year when you learn all the new moves. I'm calling my supervising physician, what do I do? This lady, Todd's paralysis. What do you mean Todd's paralysis? Well, as they come out, they may have, it's usually unilateral. No, they're not going to have both arms weak, or they're weak below the waist down. One arm unilateral, one leg. Usually the arm is what I've seen, and it may be weak for a bit, and then it comes back. They come back to normal state. That's as they come out in their post-ictal state. You may encounter Todd's paralysis, and it can scare patients. During the seizure, they may have loss of bladder, bowels, and they may bite their tongue. I would be careful on that, though. I have seen some family members that diagnose seizures just because someone lost consciousness and bit their tongue. And you will learn in practice that most of the time when a patient loses consciousness, it's probably not seizure. With how many I see that are seizures, most of them are not. Sometimes they are. So as you have a simple syncopal spell, as this patient going down and their muscles are relaxed and their tongue got in the way, that he hit the floor, he bit his tongue. It does not automatically mean no patient has. patient sees. But it's helpful for me to sometimes differentiate. You know, I'm leaning more towards seizure disorder as I'm trying to get that history of what happened, how they felt right before, what they remember, what they don't remember, what family members remember as you're trying to establish your diagnosis. But I don't see much of the loss of bladder. Occasionally they would bite their tongue though. So you want to differentiate seizures from just non-epileptic spells. I like this chart in here because I can talk about some other syncopal spells that you may have that may not be seizures. And if you work in neurology or cardiology, you're going to see a lot of syncope. And you're going to hate it in school, but you're going to love it once you get out. Exciting. We have absent seizures. We've talked about those. We've talked about focal seizures, or either complex or simple. We've talked about tonic-clonic seizure. With that, they may have an aura. They're going to shake. They may have some contraction in the muscle. And this, you are hoping that this is going to stop after 3 minutes, right? So if they're convulsing past that, we're going to start worrying. And then after that, they're going to have a post-ictal state. And if you had a patient with history of generalized seizures, and they're usually tonic-clonic when they have them, and they called you that morning and they said they had a seizure, and they're in your clinic in the afternoon, and they're happy, and they're talking, they're laughing, and they're talking to their spouse, chewing their gum, and everything's great, peachy. She put on her makeup, and I think it's very unlikely she had a tonic-clonic seizure that morning. These patients don't feel well. They hurt from head to toe. She's got a headache. She barely fixed her hair. She comes in with dark glasses. And sometimes I'll bring them in that afternoon if I want to get an EEG on them. There's a good chance that I may catch another normal EEG right after they have a spell, so I'll bring them into clinic. And so these can be quite violent too. I've had patients dislocate their shoulders. I've had patients, have a carpet burn, and she burned her scalp here and had a little big old scar as she's laying there on the floor and convulsing. So, and of course they're also whatever they may hit as they fall down on top of convulsing. So, and we talked a little bit about psychogenic spell attacks. So, if your patient has all sorts of seizures, they've got a little focal, and then they pass out, they are not the same every time, nothing adds up. This day their seizure did this day their seizure did that, and a lot of them seems to miraculously remember everything that happened during their seizure. Even as they were unconscious, they still remember a room full of people, and so it doesn't quite add up. Look for a different diagnosis, even if they're already on seizure medications. And of course, if you work in neurology, you may reevaluate their diagnosis of seizure disorder. They will go for a long time. They may convulse for 10 minutes or longer. It's a red flag to me for family members. Yeah, they laid there for 30 minutes. Did you have a question?
Oh, you can.
Oh.
But yeah.
And then, then you start to question it, and you're thinking, well, that would have been status if my patient seized for that long. And they recover very quickly too. And your focal seizure where they limb moved, they were fully conscious, there's no post-ictal state. Oh, I just saw it, okay, so that's it. But these patients, they're gonna not feel quite well. And some of them may not feel well and may have been convenient that day, and some